Hey everyone, in this video I want to talk about common ethics questions that you might get in a medical school interview. And I'm going to walk through a few different questions and explain how a clinical ethicist would answer them. But before I want to do that, it's worth stepping back and just thinking about why these kinds of questions are asked in medical school interviews in the first place. The first reason why these are asked is that it's a good test of any red flags that might pop up. So at this point in the admissions process, they've seen your MCAT scores, they've seen your grades from your undergrad, and maybe they've seen letters of recommendation if you've had to get those for that particular medical school. But they haven't had any kind of interaction with you as a person. And so one of the first things that they want to find out is that, are there any red flags that might cause issues with you being a physician? So just for instance, if you were to answer an ethics question by saying, patient rights were a mistake, we should go back to kind of pre-1950s medicine where the doctor was always in charge. That you might think that that's like, oh, doctors would want to hear that, but actually that would be a big red flag. The second reason why they ask these kinds of questions is that they want to see that, do you understand kind of the nuance or the complexity about what medicine involves? So medicine is not just about physiology and giving the right diagnosis and prescribing the right kind of medication. It is also about figuring out what the patient wants, and providing patient-centered care is about aligning the treatment the patient receives with what they're actually going to get. It also means stuff like interacting with patients and families, which is that's not really about science. That's about kind of the values of the patient and what matters to them. So demonstrating that you understand that being a good physician goes beyond just the science of it is an important thing that they want to figure out before you start medical school. The last thing is that these questions give the admissions committee an opportunity to evaluate that you understand or that you have a sense of the sorts of things that you're going to experience as a physician. So if you were to get one of these questions in the interview and said, oh, I didn't know that doctors encountered that kind of stuff, like, is that the sort of thing I'm going to have to deal with? Then that would show that, even if you're really good with science and you've got great grades, that you just don't have that much of an understanding about what being a physician involves. So these questions are an opportunity for them to evaluate that you understand or you have some sense of what medicine is like. When you're approaching these questions, I think it's useful to think about it in 3 steps. The first step is to think about the values tension that's going on. And if you're familiar with kind of bioethics jargon, or if you've taken a bioethics course, you've likely encountered the 4 principles of bioethics: autonomy, non-maleficence, beneficence, and justice. And identifying that tension between 2 or more of those values, that is a great first step, because that is a way of showing that you understand that every ethics case that you encounter that is interesting is going to have some kind of values tension. So the first step is to identify what that tension is. You can use the 4 principles, you can appeal to other stuff like fairness instead of justice, or well-being instead of beneficence and non-maleficence. Those details I don't think matter so much, but it shows that you understand or that you can recognize the complexity of these situations. The second step is then to add more nuance. So it might be more details that you understand about the case, or it might be things that you would need to find out in order to do an evaluation correctly or kind of fully about what needs to be done. So perhaps you need to get more info from a patient. In that case, one of the kind of process steps you would recommend is that you need to talk to the patient more, you need to talk to the family, or you need to talk to their substitute decision maker. Those aren't about like ethics, kind of giving the ethics outcome. Those are about showing the process that you would use to figure out what the correct ethics outcome is. You can also add any legal or other kind of context that's useful. So I think people often recommend, if you're familiar with what the law says about some specific issue, then that's fine, you can throw that in. I think the caveat with that, though, is that you don't want to rely too heavily on the law. These are ethics questions, these are not questions about the law. So if you were to answer each question by saying, well, the law says X, and so that's what we should do, that would miss kind of the nuance about what makes these complex ethics issues. So you've identified the values tension and you've added more nuance. Then at the end, you can give your recommendation if that's appropriate. Sometimes that might be pretty clear cut, but in other cases, it might be, there might be multiple kind of steps involved. It might not be about, well, here's clearly the thing that we do. It might be more about the process. First, I want to talk to this person and that person. We need to like run more tests, kind of whatever the steps are, think about getting that complexity and capturing that. Perhaps the biggest mistake that people can make when answering these questions is to go out guns blazing and say, oh, well, absolutely 100% the right thing to do is X, and anyone else who thinks otherwise is mistaken. What you want to do, even if you do think that there's one kind of clearly correct answer, what you want to do is capture that complexity, show that nuance. You can do that by following those steps. All right, with that, let's answer some questions. So the first question I want to talk about is a really common one that you see in lists of sample questions. And that involves something like, imagine that a 14-year-old comes in and wants to access birth control, and she asks that you don't tell her parents about it. So that's, there are variations on this by age and by what she's asking for, but that's a pretty common one. So the first thing is identifying the values tension. Well, it's a 14-year-old and she's asking for birth control. She doesn't want other people involved. So the tension, I think, here is between her autonomy, that she is making this request, that she wants to go on birth control, and that has to do with her autonomy, her values. And the tension that autonomy is with well-being, so beneficence or non-maleficence. That figuring out, making sure that this is the right thing for her, that this is going to be in her best interest, that's the tension. Okay, so once you've identified the values tension, it's between autonomy and well-being, then the next step is to think about nuance. This is where I would go into decision-making capacity and informed consent. So decision-making capacity is one of the conditions of informed consent. To have capacity is to be able to make decisions in the right kind of way, to like take in information and make decisions that align with what your values are. Decision-making capacity is not something that you just get when you turn 18 or 21. It's something that comes into existence and exists on a spectrum. So somebody could be 14 and could have decision-making capacity for some decision, and another person who's 14 might not. So that would be one of the important nuances to explore. Because birth control is a pretty low-risk intervention, that there aren't lots of risk, it's not something like cancer treatment or some kind of surgery, that makes it easier to justify, less risk, meaning less of a threat to her well-being. But it still might be the case that this particular 14-year-old is just not capable of understanding, balancing the risks and benefits of this, of going on birth control, to be able to give her own informed consent. So the nuance that I would offer, or the kind of like process step I would say, is that we need to have a discussion with this 14-year-old to figure out what she knows about birth control, answer questions that she has, fill in gaps about her understanding, and then also offer other kinds of information about sexual health. So something that would be important to mention is that going on birth control, like the pill, that does not protect against sexually transmitted infections, for instance. That might be something that this particular person just doesn't understand. This patient just doesn't know. And so talking about using a condom or other kinds of safe sex, that would be an important thing to offer in that case. In some of the discussions that I've seen when people talk about well-being in this case, they'll say that the right thing to do is to encourage the patient to still talk to her parents about it. And I'm actually not so sure that that's the right call in this case. You could talk to her about maybe why she hasn't informed her parents to try to figure that out. But ultimately, if you assess that she has decision-making capacity, then it's her decision. She doesn't have to involve her parents if she doesn't want to. So if you think that there is some issue, some concern that she might not be able to consent to, then you might want to talk to her about the benefit, or like why she would want to involve her parents or involve another adult. But I don't think telling her like you should talk to your parents about this, or be sure to mention to your parents that you're now on the pill, I don't think that that's the right call, because I don't think that's the right call in every situation, because she has privacy as a patient and she can make this decision for herself if that's what the assessment is. Okay, so that's the nuance to it, is that I've explained why there's this tension between autonomy and well-being. We've explored autonomy, talking about decision-making capacity, not giving a clear answer because we don't know the facts. Like, we'd have to have a conversation with her to make sure that she is capable of making this decision. We've also talked about on well-being that the pill is pretty low risk in terms of like harm reduction stuff, that if we turned her down, if we didn't give her that prescription, then that might lead her to have unsafe sex, could have put her at risk of pregnancy or of other things. Like, given that analysis, I think that the process steps I would recommend, talking to her more, if it's the case that she does have capacity for this decision, then to prescribe her with birth control. Another question that commonly comes up involves transplants. So imagine that you have a patient who's in his late 20s and he needs a kidney transplant because of a substance use disorder due to alcoholism. Should you put him on the transplant list? Now, the tension in values here is between, you could make a case for a few different ones, but I think the clearest one is between beneficence, or his well-being, he needs this transplant to survive, versus justice. So the concern that I think that this case is supposed to motivate is that because of his substance use disorder, that it seemed like people might argue that it's a misallocation of resources, that they might say that he brought this on himself and so he shouldn't get the transplant, somebody else should get it who gets sick or needs a kidney transplant through no fault of their own. So we've identified the values tension, let's say well-being or beneficence versus justice. Now you can add more nuance. And this is where to explore the ethics of treatment for substance use disorders. Now, I think that there are a couple things to mention. One of them is that substance use disorders and addiction, I think the most common view now is that these are a type of disease. It's a type of disease like any other. And so the reasons that people get substance use disorder is not kind of by choice, that they decided that they were going to drink a lot of alcohol and that was like an informed decision. It comes about through circumstances in their life. There might be genetic disposition towards addiction, and these kinds of factors make them less kind of responsible for having the disorder in the first place. But even if it were the case that the person brought it on or played some role in bringing that about, still not clear that that means that they should get deprioritized for the transplant. Think about somebody who goes out rock climbing and he falls and he hurts himself really badly. Now, he made the choice of going out to go rock climbing, but does that mean that we should deprioritize him because he had some role to play? I think the answer is no. Similarly, for somebody who goes driving on the highway, made the decision to drive on the highway and ends up getting in a collision, should we say they should be deprioritized because they made the choice to go driving on the highway? I think the answer is no. I think that ethically in medicine that we shouldn't evaluate whether people we shouldn't evaluate the treatment that people get based on kind of deservingness. Instead, it's about ability to benefit. That brings in the kind of second nuance point, which is that it might be the case that there are many cases of people with substance use disorders where their ability to benefit is limited because of ongoing substance use. So one of the details to find out or to explore is this person still using substances, to what degree, and how much can they benefit from it? So when thinking about justice, about who should get the transplant, one of the things that matters is who's going to benefit the most. And if somebody can benefit a lot more than this person, then there's a case for giving them the organ just because they have more ability to benefit. Again, that's not about who deserves it more, it's about what's going to make the best use of the resources. Okay, so explored the values tension, explored some of the nuance. I think the answer then, once we've kind of explored some of those other details, is that he should be put on the transplant list if he needs it and if he will benefit from it, which seems like he will, then we should put him on the transplant list. The last case is about truth-telling. So suppose you have this patient and you've just gotten his test results back and he has cancer. So you're going to go in and tell him about his diagnosis and then talk to him about it. Before you do, his wife comes up to you and says that his mom died of the same kind of cancer years ago, and it absolutely destroyed him. And so she thinks that he wouldn't want to be told about the diagnosis. So she asks you, can you please not tell him the diagnosis and leave it up to us, the family? The ethics tension in this case is between autonomy and well-being. So for autonomy, he has a right to know information about his diagnosis, and this is important not just so that he can make treatment decisions or he can decide what kind of healthcare he wants, but also because this is something that will really affect his life. So imagine that he only has a few months left to live. With that information, then he can decide, use the time as well as he can. But without that information, that he might make decisions that kind of on reflection, or if he knew the information, that he wouldn't otherwise make. The other part of this tension, kind of on the other side, is about his well-being. His wife, part of her claim is that she's saying that if we tell him, it's really going to destroy him. It's going to have a huge emotional effect on him, and he would be better off not getting this information. So this is a tension between kind of two parts of autonomy about what he really wants. So we got to try to figure that out somehow. And then also about what's in his best interest kind of overall. The first step, kind of exploring the nuance about it, is on the autonomy side. And this is a genuinely tough case because it is hard to figure out what he would want without telling him the information. So by kind of disclosing information, then we're like telling him the thing that he might not want to hear. So that makes it a tricky situation. On the well-being side, part of the nuance is about whether it's actually in his interest, like what effect this is going to have, and then what he might choose, how he might want to weigh those. But in general, this kind of reasoning is a type of paternalism, arguing that we should not give him the info because that will be better for his well-being overall. There are rare circumstances where it's appropriate to withhold medical information from a person who can make his own decisions, like this guy. But I don't think that this is really one of those cases. So in situations where telling somebody information could put them at grave danger to themselves, that they might take their life or that they might experience extreme psychological harm, then I think that in those cases you can be justified in withholding information. But based on the info that we have, maybe there's kind of more to explore with the wife in this case, but based on the info that we have, it doesn't seem like it's going to be at that level, and so we should go ahead to tell him the information. The way to do that, and this is kind of the third part of the puzzle, is by introducing information kind of in a stepwise fashion and then leaving it up to him by taking cues off of him about how much more he wants to know. So I think that asking him if he wants to get the diagnosis, get the results of the test back, and then giving him kind of the broad kind of overall strokes about what the diagnosis is, and then taking cues. So that might mean asking him, how much more do you want to know, or what questions do you have, and then continuing to explore it. I think that minimally he should know his diagnosis, and he should know kind of what the outcomes, like what the prognosis is going to be. I think withholding that information in that case would be wrong. I think that that's true even if, once you told him that, if he had said, oh, I never wanted to know this, I wish you had listened to my wife, that there was no way for us to verify that ahead of time. Unfortunately, in this kind of case, there just is no way to know what he would do because he has to have that information to make that choice. So I think in these kinds of cases, the thing to do is to err on the side of giving him the information so that he can make an autonomous decision. And after that, if there's more that if he doesn't want to get more info, if he says, okay, thank you, like that's enough, then respecting that decision. So I hope this has given you some insight into how a clinical ethicist would answer these questions. I think that the best thing to do in terms of preparing for a medical school interview is to look at as many of these questions as you can. You can look up question banks online, and you can practice saying them out loud with a friend or colleague. And I think the core part of it is focusing on the ethics tension. That is the key piece of it. After that, add as much nuance as you can. All right, thank you everybody so much for watching. See you in the next one.